You're listening to the Patient Advocacy Now podcast, presented by Greater National Advocates.
It's just gut-wrenching sometimes. Like, if it's sad and they're crying, I might cry.
Amazing how many doctors do not even want to treat somebody who has Medicaid.
Medical system is about making money.
And I said, so are you hiring more nurses, or you're just telling each nurse to work harder?
Let's dive into the nasty. Let's dive into the bad. Let's talk about all the big problems you see with your experience, not just as an advocate, but as an ICU nurse with where healthcare is today.
Oh, well, that's one of my favorite subjects, John. And I could go on for way too long. So just stop me about this. I became a professional patient advocate in 2011. At the time, I was working full-time as an ICU nurse in a cancer hospital. And I saw a lot of the changes that were coming down as hospitals were getting ready for the Affordable Care Act, because it was going to be a completely different form of healthcare in America. And I saw that it was so heavy with the documentation. And, to me, it's not rocket science. You take doctors and nurses away from the bedside, you're not going to get safer care. I was very, very concerned. And I actually saw that personally myself in the intensive care, because nurses are so afraid of the documentation specialists. And we were going heavy computer. We went from spending 20 or 30 minutes a day charting to 2/3 of our 12-hour shift charting. And nobody really had time to read all that stuff anyway. And I thought, oh my goodness, what's going to happen to healthcare? And so
just to clarify, because I actually wasn't involved in this space back then. So the big shift was there was this huge barrage of paperwork requirements that was just thrust upon doctors and nurses.
Yeah. Pain, two-step process. Now there were 14 different steps that we had to do from the time the patient asked for a pain medication to the time that we brought it back, and patients were angry about it, but I had to go find another nurse on a busy unit, say, hey, can you come and witness this, because I have to waste half of this medication. I want to make sure that you're counting things correctly with me. And they were expecting nurses to do more and more non-nursing things. And I remember the education department came up one day and said, oh, now we want you to start documenting how long it takes for doctors to answer their pages. And I said, no, I'm not going to do it. I'm already doing like 20 things that have nothing to do with providing good nursing care to my very sick ICU patients. And I cannot document how long it's going to take each and every doctor to return their pages. I have more important things to think about. So those were just a couple of the little thoughts that came to mind. But I remember one day, my nurse manager and I were both working together on this one very sick young woman with lung cancer. She was probably 41 years old, and she had come up to the ICU with respiratory distress. And so we settled her in. I took one look at her and thought, this woman's going to end up being intubated within the next hour. And so I helped get her settled. The nurse went out to the desk and started charting while I went and took care of my patient. Well, 20 minutes later, I came out and she was still sitting there charting. I looked at the patient and she was having agonal respirations and her heart rate was starting to slow down. So I went in there, I called a code, and that was very scary to me when you have really good seasoned nurses that are so afraid of charting things incorrectly. Because we were told if we didn't do all of our documentation, we could potentially have our paychecks withheld. And so I thought, no, this is not the kind of world that I want to live in. And not too long after that, our family went on a cruise to Belize. And if you want, I'll just tell you how I got into patient advocacy. It was pretty dramatic, like Brad's story too. And And so we went on a cruise to Belize, and my father-in-law, the patriarch of the family, he was 76 years old, and 2 days into the cruise, he had a near-death experience. He fainted outside the dining room, and when I went to pick him up the next day, his legs were swollen and starting to turn purple. And being an ICU nurse, I knew we were going to have a medical emergency pretty soon. So I took him down to the ship's doctor. They didn't have any scans on board ship. And I said, I think we need to get him to a hospital and be evaluated. He agreed. So I got in this little boat with him and went to the local hospital. And I had done a lot of medical mission work before, so I knew what third world country hospitals look like. So I was kind of curious. And this one was better than a lot of the places in rural Africa, but they still didn't have basic diagnostic equipment. And so I told the doctor on the ship, I think he's clotted off his IVC filter, which is like a little filter that sits in your aorta and catches blood clots to prevent pulmonary emboli. And so anyway, we just empirically put him on a blood thinner drip, heparin, but most people don't understand heparin doesn't dissolve clots. It just prevents further clots. And it takes your body like 7 to 10 days to, dissolve that clot. So 3 days later, the little doctor comes in and says, oh, he can get up and go to the bathroom now. And I thought, that doesn't sound right, but I didn't want to be that problem family member. And, and so we went to the bathroom, and 2 minutes later, I knocked on the door, and he said, I don't feel good. And I opened up the door. He was purple from his head down to his toes. I carried him back to bed. We ran a code on him for 5 or 10 minutes, and then I just said to the doctor, we're going to go back to the U.S. today. But unfortunately, we got back to the U.S., and I was heaving a big sigh of relief, went to the emergency room at the local hospital. And I was so relieved to see the head of the emergency room working that night. And I told him the whole story. My father-in-law couldn't even stand up without fainting. And so I didn't want to be Miss Bossy Pants, but I figured he'd be able to figure out what was wrong with the patient. And so he went out and called the primary care doctor and came back and said, well, these things happen sometimes. We're going to just send him home on some subcutaneous heparin and he'll be fine. And I said, no, that's not going to happen. I pulled him outside the room and I said, you just tell my cardiologist friend that Teri Dreyer's in the emergency room and she's being difficult. And so the next morning, my father-in-law underwent a 4-hour procedure to remove blood clots from his ankles all the way up to his diaphragm. And then over the next 6 weeks, he had many, many, many different near-death experiences. He was either bleeding to death or clotting things off. And so the whole experience just really taught me that to be a family member of a very sick client is a very, very scary situation. And sometimes nurses and doctors with family members in a crisis like that, we know too much. So we know the worst possible scenario, what can happen. And so we want to be reading all the labs and the charts, and we know what the norm is for the patient. We use good common sense. Anyway, not too long after that happened, I had a very dear patient in ICU who experienced a crisis, and she almost bled to death 3 times after this massive surgery procedure for cancer, metastatic cancer. And when I asked the doctor why he wasn't doing more diagnostic tests, he got really offended, almost threw a chart at me, and he transferred the patient out of ICU the next day. Well, the family came up to me crying and saying, Teri, mommy's going to die. You have to do something. So, I did what any good patient advocate nurse does. I pulled her in a room and I said, this is what you need to do. You need to go down and tell the doctors, mid-level practitioners that the patient needs to go back to ICU, needs to go to CAT scan, and get an interventional study to find out where the bleeding is coming from. And if you're not willing to do that, then I want to talk to risk management. And so that's what happened. I picked up the patient, took her to the lab, brought her back up to ICU, and we gave her blood all the time. She was bleeding to death. And long story short, we did a 4-hour code. And during that code, I forgot to sign out a narcotic while we were intubating her. And then that doctor in his mid-levels tried to have me accused of being a drug-abusing nurse. So that was kind of that was kind of the big light bulb moment, John. It was like, okay, I guess nurses can't really strongly advocate for patients anymore. And so, that was the best thing that ever happened to me, because when I got that upset about things, I mean, they put me on a 10-day suspension, and it only takes 10 minutes to get a urine drop back. They made me do a urine drop to see if I had drugs in my system, and I was just so insulted and so angry. I'd been one of their top ICU nurses and mentors for 23 years of my life, and they were choosing this doctor over me when I was strongly advocating for the patient. So to me, I just said, okay, this is not okay with me. I can't work like this. And so I left and started my own company. I'm sure everybody thought I was crazy. I had no business degree. I had no background. I'm a 3-year diploma RN. I don't have my PhD or my master's or anything. My passion drove me to start the company, because I said patients in America are going to need people to keep them safe, because this new system we have is going to lead to fraud, corruption, worsening patient safety ratios, and poor care. And I think we learned during COVID that the fractures in healthcare became like the Grand Canyon. All the problems in healthcare during COVID became patently obvious to everybody. And so when you make medicine really all about money and move the patient out of the center of the model of care, it's not going to be a good thing, and the whole healthcare system in America right now is so fractured, and I don't believe the government can fix it. I believe strongly that every patient in America, whether they're rich or poor, should have equal access to the highest possible quality of healthcare. But when you make medicine and healthcare practice all about money, there's a certain segment of society that sees what's going on and says, I'm not going to do this. I'm going to hire somebody to help keep me safe. And so that's why the field of professional patient advocacy is growing so much. And it's not that we're against hospitals by any means. We just know the problem is so big, we choose to make a difference in people's lives, one patient at a time. So that's where I am. I got off track. What's the next question, John?
Has it gotten better or worse since the Affordable Care Act in 2011?
Oh, much worse. Yeah, much, much worse. I mean, why do you think we have such a mass exodus of doctors and nurses now? I mean, clinicians.
Is there more paperwork? Is there more regulation and red tape? What's the problem?
It's not patient-centric, no matter what the marketing people will tell you. It's really all about moving people through the system as quickly and efficiently as possible, but nobody really has time to read everything, and you have silos and miscommunication that lead to needless medical error and death. So the patient safety stats have not gotten better. In fact, I believe they've gotten worse from what I've seen over the years. And I don't think the government can fix this. I think it really needs to come from a strong grassroots movement of doctors and nurses inside the hospital and patient advocates outside the hospital saying, no, this is not okay. So
do you see this the start of that anywhere across the country?
No, people have been talking about universal health care for everyone, but the American culture is so different from other countries. I've done medical mission work in Africa and Europe and South Africa. I was there 7 times. And so other countries that do employ somewhat of a socialized healthcare system, like Canada, Canadians are not happy. I mean, if you have cancer, you don't want to wait 4 months for a PET scan or an MRI scan. So Americans are not going to tolerate that. But more importantly, I think big pharma and the insurance companies are not going to tolerate it either. They're very powerful lobbying folks, and really they're the only ones making money during this part of healthcare. Good hospitals are going out of business because today it's you either go big or go home. You can't give that concierge level care because everybody has to see more patients in a shorter period of time to just break even.
Yeah. Well, let's switch gears a little to the advocacy space. It's still a new space, still kind of emerging. What's your view of the industry as a whole, patient advocacy? Do you feel like it's headed in the right direction? What are some areas of concern?
Well, I think first of all, there's a lot of confusion about what advocacy means because you have disease-specific advocates, you have insurance advocates, you have hospital advocates, which work for the risk management department of the hospital, so their job is to prevent the hospital from getting sued a lot of times. And what I'm talking about is private professional patient advocates. That movement is completely committed to patient safety, high quality of care, empowerment of the patient, keeping the patient the center of the model of care. When we show up with our clients, and we call them clients instead of patients because we're really consultants. I have my RN degree, but I don't practice hands-on anymore. But in my brain, there's, like 40 years of clinical experience. So that's valuable. And I understand how the healthcare system works. So the field of advocacy, first of all, it's very confusing to people. What's the difference between a patient advocate and a care manager? Well, a patient advocate is a much more robust model. We're like having a nurse in the family or a doctor in the family. We go to the wall for that patient. We do a multitude of things. We vet facilities. We don't just move people through the system. Right now, I have a very complex client that has end-stage renal disease. He's going to end up on either dialysis or a kidney transplant pretty soon. But his biggest problem is that he's got a Medicare Advantage program. So that doesn't give you open access to every place that can give him the best possible care. So right now we're in the process of getting him switched to the best possible insurance he can afford. And it's sad to say because everybody should have the same ability. But when you make healthcare all about money, that does not happen. Medicare Advantage advantages the insurance companies. They have much more narrow networks, much more restrictions. They're geographically limited. And Medicare Advantage reimburses doctors and hospitals so much less than traditional Medicare that the money part gets in there. I feel like the patient advocacy movement has been growing quickly the last year or two. I mean, the numbers are staggering how many people are leaving. The head of the Patient Advocate Certification Board told me yesterday that she got calls from 20 physicians in the last 10 days wanting to know more about how to become a private professional patient advocate because doctors aren't happy. They want to spend time with patients. When all this started happening, doctors started making much less money, but we're still, a lot of them are employees of healthcare systems. So you have allegiance issues when that happens. Yes, the doctors get their malpractice insurance paid, but they don't have the ability to make as many patient focused decisions as they need to, because the financial departments of hospitals are coming down all the time saying, is he medically stable to leave? Is he medically stable to leave? Is he medically stable to leave? And, a lot of times doctors are getting so much pressure by the case managers in the hospital to move them out so the hospital doesn't lose money. If somebody's pronounced medically stable, then they stay in the hospital. Every day they stay in the hospital is going to have to eat $6,000 to $8,000 minimally. So that's what I'm saying. It's not a good system that focuses on what's best for the patient. So patient advocates will go in there and say, we need another 2 days or so, and then we help the case managers find a safe discharge plan. I mean, Medicare and insurance companies say that you have to have a safe discharge plan, but when you're under the gun for losing all that money, and there's a growing number of senior orphans and adults with disabilities that have no idea what to do, you're going to need more and more advocates. My hope and dream, John, is that we will figure out a way in this country to have everybody work together so that advocates eventually can have the autonomy to do what needs to be done ethically, but not have to do mounds and mounds of paperwork. Right now, the industry is independent. So, and I feel strongly that the allegiance factor will be compromised if we get into bed with Medicare or private insurance companies or the big pharma companies or everything. Yes, we can save them tons of money, but then they're going to tell us how much time and what we can do as clients. And these people do not understand the community like patient advocates do. We know where the best and worst resources are. We don't have to send them to bad nursing homes because they're in the post-acute network of hospitals. We advise people where to get the best care because the only person we really care about is the patient. Understand?
Yeah. You mentioned that doctors were making much less money as this started progressing. Let's talk about that for a little. I mean, I think you're in a position to speak about the financial ability since you've started different advocacy groups. So, if I'm a nurse listening to this and saying, well, yeah, but how much can you really make as an advocate? I don't want to lose all the safety net. Because there are people I've talked to nurses, offline who it's a kind of a new burgeoning field, and they're thinking of the advocate, like you mentioned, as the one who works as an employee making maybe a third or a fourth of their salary for the hospital, and they're like, "What am I going to like? That's not going to cut it." So speak a little bit to that.
Yeah. Okay. Well, should I talk about the doctor aspect or the nurse aspect first?
Let's start with the doctors and then move to nurses quickly.
Okay. Well, the last time I worked in an ICU, it was part ICU, part stem cell transplant unit. And I remember one day I was working with a doctor who was a stem cell transplant expert, and I was working with a pulmonologist, and they were doing a procedure. They were putting a big catheter in, and I was assisting and showing them how to do, some of the stuff and handing them the right things. And they were having a conversation over this patient that was comatose. And I remember the guy that works stem cell transplant was asked by his colleague, well, do they treat you well here at this hospital as an employee? And this young doctor who was super smart, had probably spent hundreds of thousands of dollars on his medical education. He did get his malpractice insurance paid for, but he said, "Oh yeah, they pay me really well. They paid me like $120,000 a year." And I was shocked. I said, "Seriously, you go all the way through medical school?" I'm a nurse. I'm making almost that now, working 3 12-hour shifts a week. And I thought, something's wrong with this picture. And so doctors are leaving primarily because there's so much pressure for them to take more Medicaid and Medicare patients. So the little private doctors really can't compete. And the way insurance is set up now, the insurance companies don't want cardiologists, for instance, to be doing stress tests and scans in the office. They want them to have it done at the hospital. It's all about bundling of payments and the how the money systems work. Everybody kind of gets into bed and with each other and shuttles people through the system, and they get more money. So the little guys that really try to be good doctors, and before the ACA, they were doing 20% of their work pro bono anyway, because most doctors did. Well, now, like today, I just got a bill. My Blue Cross Blue Shield company billed $897 for a test that I had, and the insurance company paid $173 for it. So I don't owe anything because Medicare doesn't have to. But if you figure that out, every doctor I talk to, it's almost impossible. A lot of them are going to concierge medicine because they don't want to be employees, because the employees of the hospital that are physicians are worked to death. They're just
And after 12 years of schooling and residency and specialties, and
yeah.
your point, why are you getting into the field?
I know. And then they have so much pressure from the higher ups to do more, see more patients, because they have to see more patients to stay alive with the hospitals. So most of the general public doesn't realize how fractured our healthcare system is, but it's too big for me to make any meaningful change. I'm just going to make a change one patient at a time. And it's very rewarding work, very rewarding.
So back to the finances, is there a way for a doctor or nurse to actually make a living that's worthwhile for them?
Well, sure. I mean, most of my students in my Nurse Advocate Entrepreneur program will still keep their day job, and then they'll take my course and they'll start slowly taking on more clients. Most nurse advocates and physician advocates around the country make between $250 and $350 per hour. Okay. So if you're used to making between $40 and $60 an hour, I mean, granted, nurses made exorbitant amounts of money during COVID, but that kind of model can't last forever. So I have a student now that works ICU. She just cut down. She just got a client. So, I mean, in 5 hours, if you can make over $1,000, whereas, before, I mean, yes, you still have to pay taxes and business expenses and everything. But to me, it's a great model. It gives nurses better work-life balance and doctors. They can spend as much time with the patient as possible. And for those that say, well, what about the people that can't afford $200 an hour for an advocate? Well, I would say two things. First of all, every advocate that I know, including myself, does some pro bono work and lowers their prices for people of low income because that's the right thing to do. And second of all, I've had many, many clients before that just love their family members so much, and they had a big family, so everybody pitched in, a couple $100 here, a couple $100 there, and pretty soon I've solved their problem for them. So we don't milk people for the long term. I'm the oldest of 9 kids, so if somebody in our family had trouble, all of us would have enough money to pitch in to have somebody privately stand guard. Sometimes I describe what I do is like being part advanced practice nurse, part lawyer, and I know a lot more about patient safety and patient rights than most lawyers do, and part guard dog. We're very polite when we go in the hospital, but our whole focus is to keep that patient safe, give them good options, not let their rights being violated. And that's such important work today.
Is Is that the hardest part or the biggest gap in knowledge for a nurse to kind of learn that kind of more legal side of it and the navigation?
Well, that's a great question. I'm glad you asked that because since 2008, when the first advocacy organization was formed, nobody's ever sued a patient advocate because we were protected. We don't ever tell anybody what to do, and we don't do hands-on care. The patient is the center of everything. I've had many patients that made bad decisions in their life, but if I give them 3 good options and explain carefully why and develop that trust with them, I'm going to go where they want to go. They're in charge. They're the center of everything that we do. And that just it's very inspiring. I mean, most of our clients are not wealthy people. Every once in a while we have somebody that says, money's no object because they really care about their loved one, but maybe they live on the other side of the country. And that's a growing demographic that is meaning that more and more people are going to need professional patient advocates. People get old, they get memory problems. Their son and daughter live in another country, or, you're in California, I'm in Massachusetts. What are you going to do when mom is starting to decline and you can't be there to be her personal family advocate? So a lot of people are choosing to hire somebody that's like a watchdog.
Yeah. And that, I assume, that takes a different mental headspace and expertise than just your classic RN or LVN, or RMPA kind of like training. That's part of what you probably go over when you train advocates.
Well, it is. And the funny part is that the part that people find most intimidating is the business startup and sales. And I love talking to people about what we do. And I have a very conversational style that is non-threatening and easy to learn and memorize to just show people what we do. Like if somebody came up to me at a party and asked me what I did for a living, I would just say, basically talk about the problem, the solution, and the results. Okay. So I would say, well, with all the current healthcare problems and concerns over patient safety, the average family member or patient are lost, confused, and frustrated by modern healthcare. Our nurse advocates are able to untangle all kinds of messes and bring peace of mind to families that just want safe care for their loved one. So that's very conversational. It's not salesy. And we practice a lot of these techniques, but nobody likes to see themselves as a salesperson. But most of the nurses, when they graduate my program, they start telling their friends what I do, and they get clients really quickly because they're so passionate about the importance of what we do. So I think
I've seen that. I've seen that in hosting this podcast, talking to advocates. That is the biggest hurdle for a lot of people. Went straight from school to the hospital and never kind of learned any of the business acumen, sales, marketing. And they're like, well, what do I do as soon as I get this certification? Or
Yeah, exactly. Well, the business startup is the easiest part. And I teach that in 1 hour, how to start your business legally. But the networking, the marketing, the sales, how to tell people what you do, that's the most intimidating part. But I try to hold them accountable with a certain number of networking meetings and one-to-one meetings. And I've learned over the years which types of professions are most likely to refer people to professional patient advocates. So it's
have there been any surprises now after you've been doing it for so many years? Like, I didn't think plumbers would refer so many people or whoever it is.
well, in terms of referrals, well, lawyers, definitely. A lot of my best referral sources are attorneys because, first of all, they get our income model, so they know if people can afford us or not. But they don't know anything about healthcare. And lawyers like to be the hero, right? So if they refer clients to us, then the patients are going to go back and say, man, That is the best money I've ever spent. I am so glad she saved my mom's life and things like that. So the word spreads. So I had no idea that lawyers would be great referral um, people. But yeah, I've learned a few things over the years about what works. And mostly I just want to help people save money too, because a lot of nurses are the primary breadwinners in their families. And you have to watch your dollars. Don't throw money down the toilet. Like one thing that was a surprise to me in the beginning was that paid marketing doesn't work. It's a very relationship-based business. You have to invest time and talking like I'm talking to you and explain to people and tell stories that they see all the time. I try to tailor.
I think it's just too new. I think that's also part of it, is that the idea of an independent patient advocate is too new. It's part of the reason why Greater National Advocates,
Yeah.
part of the mission is spreading the awareness that something like this.
Yeah. And it's really, really important work. I love the fact that Brad saw the need from a personal vantage point a couple times now. And so he's kind of like the poster child, the head of GNA. He turned a tragedy into a huge blessing for patients all over this country, and how he's improved access to advocates just through his wonderful website and all the things that he's done to spread the world. And I just have so much admiration for that. Brad's been like a brother to me for over 10 years. He's just a wonderful human being, and he's fun. And I love him to pieces, but I think what he has done with the tragedy of his story is wonderful. And we're all over the country. We're looking forward to seeing Brad on the February 20th interview with your podcast. That's going to be wonderful.
Yeah. Tell me about, I mean, you talked about some of the kind of pointers and different angles you've learned, like working with attorneys over the years for business and not wasting dollars on marketing. Tell me more about your online kind of digital training, nurse, advocate, entrepreneur.
Oh, okay. Well, I have 3 different options. I take on a few one-to-one clients, but most of the people sign up for my live coaching cohort. We meet every Wednesday. They watch a 1-hour video beforehand. We go over the video, we do practice, we check in with each other, and that I hold about once every 4 months. And for people that have a very, very busy life, and they don't know if they can commit to that, then I also sell my lowest end program is just the 13 hours of pre-recorded video. And there's a book that goes with it called nurseadvocateentrepreneur.com. That's the 3rd book that I've written, and it gives people I give people thousands and thousands of dollars worth of legal forms and marketing materials, and the mentoring is powerful. That's what I'm most passionate about at this point in my life, because for the last 10 or so years, a lot of people around the country recognized me under my previous married name, Teri Dreyer, and I've met them at national conferences and everything. But I've been mentoring people just on the side whenever they need help for most of the last 15 years, and I love it. It feeds my soul to be able to have people just call me immediately and say, Teri, I just got this new client. What do I do with this person? How do I organize it? And they've already studied all the material. They want somebody to hold their hand and confirm that they're on the right track, and what kinds of people we need to work into the care plan, and what the focus is and everything. So it's very, very rewarding to teach and mentor up and coming nurses. And I don't just teach nurses. I've taught this to physicians. I've taught this to social workers. I've taught this to people with masters in public health. It's not just, I just speak from a nursing vantage point. And I think if you have a very medically complex patient, you really need somebody that's an expert at patient care in some aspect in the hospital, because it can save your life. There's a lot of assessment things we don't even realize how much we know, and things that are common sense to us are absolutely amazing to the general public. Just just something as simple as, when you go into the hospital, don't lie in bed all day. Make sure you get up and sit in the chair and eat all your food. I don't care if you don't feel good, but you're going to get so weak, they're going to want to send you to a nursing home if you don't get up and move around and eat. Because if you get malnourished in the hospital, your muscles start wasting away, you're going to get bed sores, and it's going to be like one domino effect after another. So simple things that nurses always know that are just so obvious to us are not obvious to the public. So that's what I love to do. Anything else, John?
No, that's good. Anybody listening who wants to work and mentor under Teri Frykenberg, go to nurseadvocateentrepreneur.com. She's a wellspring of decades of information at this point, going on to your second decade of advocacy and much more, even as an ICU nurse. I can't thank you enough for being here.